As I said in the announcement I posted, when I followed last year's class's advice about combining cortex and thalamus, I hadn't realized as I was doing it that I took what had previously been 4 sessions and combined it, and by eliminating the repetition as I introduced topics in advance and reintroduced them later, went down to 3, which is why I got slightly out of alignment. So we're going to get back by taking advantage of that extra day to do the bits that I dropped from the thalamus lecture, the cortex lecture, and then Friday's basal ganglia lecture, and go back and think about cerebrovasculature. As we think about it, we have this whole complicated structure that we need to get blood to. We need to get blood in. We need to make sure that that blood is oxygenated. So it needs to come from the correct side of the heart. The lungs have to be working in order to have it oxygenated. We need to have it also have glucose, because brain essentially has minimal intrinsic stores and uses glucose almost exclusively as its metabolic energy source. So you need to have glucose, you need to have oxygen, and you need to have flow, okay? Because flow is really important, because you also need to clear metabolites as well. And so the getting out what you need to get rid of as well as getting in what you need is essential. And the body actually puts a lot of effort into maintaining that. And you'll see in a moment, I added a couple of slides after I thought about things that I forgot to mention in the lecture when I was driving in this morning. And we've already talked about parts of vasculature that cover brainstem, cerebellum, and cord. And I'm actually going to go back and review them as sort of the build into the full system this morning. So when we think about vasculature, we need to think not just about blood flow coming in, but about how the system is going to regulate itself. Now, I've already mentioned one type of regulation, okay? It allows you to do fMRI research, hundreds of thousands of NIH dollars spent each year watching people in scanners do tasks. What is that relying on? Why is there a signal when you do something? You're not measuring neuronal activity. What are you measuring? Blood flow. So you have to be able to link neuronal activity to blood flow. At the same time, when you stand and sit, or lie down and stand up, your blood pressure changes, okay? Those of you who've been through cardiovascular know these physiologic responses. In lots of situations, your blood pressure and heart rate fluctuate, right? Your brain perfusion shouldn't fluctuate unless you expect your cognition to fluctuate, okay? And having your cognition fluctuate like that is not a particularly good thing. So you're going to have the ability to maintain perfusion. And finally, you need to maintain it, and in the absence of maintenance, you're at risk for stroke. And we'll talk about all 3 of those. But when we think about vascular perfusion, we have to think about things such as the resistance of the vascular bed, and where does it happen, and where can you modulate it, okay? And what this figure that I found is really quite nice about, and it gives you roughly the ways to think about it. And people know the various rules, like when you think something is common but not very common, what's your rough guess for percentages? 80-20? Okay, 80-20, that's sort of like the standard estimate if things are common, not common. You think things are pretty evenly distributed? Typical thing is like a third, a third, a third. So here when we think about where cerebrovascular resistance lies, okay? I mean, here it's actually, they give you 39 and 21. Think about it this way. It's 40% in the big vessels. These are the vessels that have names, okay? Large cerebral vessels. It's about 20% in the vessels that come from them that sit on the pial surface. And the other 40% is down in the parenchyma. The different types of brain regulation of perfusion are going to happen at this level, where we're going to get sort of the so-called, this is going to be the autoregulatory for the most part, and this is going to be the neurovascular coupled, which is This is so-called neurovascular unit, which is neurons do some sort of change that change vascular function, and what sits in between are glia and pericytes. Okay? So we're going to talk today about the names, internal carotid, middle cerebral, circle of Willis, and so on. We're not going to name these peel arterioles, and we never name the penetrating arterioles, but they each contribute distinct functions to cerebrovascular regulation. So the migraine physiology is really a mess. So it is a combination probably of medium-sized arterial vessels, which is why they tend to affect territories, and the neurologic consequences that are aura are in fact a phenomenon known as spreading depression, which is a sort of field effect across cortical areas that you'll talk about a little bit in the context of epilepsy. But the issue of what makes it painful is probably dural innervation, not brain. So brain itself has no sensory innervation, which is why neurosurgeons can do awake craniotomies and manipulate brain without pain. What's anesthetized is scalp down to dura. Okay. So the three critical concepts that, as I sat at the traffic light on Route 9 this morning, that I realized I didn't say when I went over the slides this morning practicing, where the first is this concept of hypoxic ischemic injury. If you remove or block blood supply to a segment of brain, you will lose the functions eventually that are associated with it. That's what that exercise in brainstem strokes was that we did in lab a week and a half ago. Okay? And we'll talk about more of those this morning. The next is the neurovascular unit. We already mentioned that. That's the local regulation of blood flow in response to activity. Basically, neurons become active. They need to pump more ions in order to maintain their ion gradients. Okay? In order to do that, they need to generate more ATP. In order to do that, they want to make sure that they have an adequate supply of oxygen and glucose. Therefore, they drive local vasodilation, and it's that increased perfusion and increased oxygenated hemoglobin that you actually see as the bold signal in MR. Okay? And the last is this cerebrovascular autoregulation, where the goal is not to be responsive, but in fact to maintain perfusion at a constant level in the face of fluctuating external circumstances. Okay? So, hypoxic ischemia, words that you should know, and you'll hear these again at the end of the course when, I'm not sure who gives the lecture this year, but there'll be a lecture on stroke in terms of clinical symptomatology and management. So there's a term, the penumbra. Penumbra is used to describe an area around the center of a lesion, which is mildly underperfused. So it is mildly hypoxic, mildly ischemic, and at risk. So that if you can devise therapies that enhance the ability of cells to resist low oxygen, low glucose for a while, you have the hope of making something a smaller stroke. The second is that the major therapies that have emerged for stroke once it happens, separate from preventive measures, okay, but once it happens, for embolic or thrombotic strokes, all of the biology that has been done for neuroprotective studies and molecules over the last multiple decades is a complete clinical waste. None of them, despite having worked in cell culture and in animal studies, has ever worked in humans. The only things that work in humans are plumbing. Basically two things. Lysing the clot with an enzyme that dissolves clots, so intraarterial TPA, okay? Lyses clots. If it's given in an appropriate time window, it commonly reverses symptoms and leads to no long-term deficit. And the other is fishing it out with a wire, okay? This is a clot retrieval device. It's basically threading a catheter with a wire that you shove through the clot and you yank back and you pull it out of the way. And if you do that in a timely manner, people get better, okay? So people can come in and have the emergence of new onset, devastating neurologic symptoms and be reversed and go home the next day whereas previously they would have been left with those symptoms for the remainder of their lives. Okay? The problem is that if you do those in the setting of ischemia that is too far advanced, what happens? Remember this from pathology? Yeah, if the endothelial cells are also ischemic, what happens? When you reperfuse, you take ischemic cells, you now provide them oxygen. You generate more oxygen radicals than they can detoxify. You further the injury. You injure endothelial cells. What happens to your vasculature? It leaks, and you end up with hemorrhage. So hemorrhagic conversion of stroke after ischemia and reperfusion is the risk. And that actually is what limits the time window during which this can be done. And there's great uncertainty. There are current clinical recommendations about safe time window. And what matters is time since last seen well. And here's the problem. If you wake up with your stroke and somebody notices it then, no one knows when it happened. That's very different. So if you went to bed at 10 o'clock and you're seen the next morning at 9 a.m. with your stroke and it happened at some point during the night, no one knows when it happened. And so you're not going to be able to get thrombectomy or clot lysis. As opposed to sitting in your office having the symptoms emerge. Somebody goes, it started at 8:45, and at 9:45 they're in the ED at a hospital having the procedure done. Okay? Those are the people who benefit from it. Whereas people who don't have known time of onset, it's very hard to treat. So that's hypoxic ischemia. The second is the neurovascular unit, and we talked about this already, that there's some coupling between neuronal activity out here in the neuropil and the capillary diameter and the arterial diameter. These have smooth muscle cells, these don't, but the neurons and astrocytes interact with the pericytes and the smooth muscle cells. And there's unclear coupling, but it critically depends on all of those components. You need the neurons to have activity. You need astrocytes because they're the direct link to the vascular wall. You need pericytes on capillaries, and you need smooth muscle cells. And dysfunction of any of them leads to dysfunction of the neurovascular unit. What's missing from this paper, because it's about 3 years old, which is the last time I gave a talk on neurovascular unit, is now people have shown that there are factors and contributions from microglia. Microglia are largely the flavor of the month in all of neuroscience. So whatever assay you used to do, you can republish all of your papers now showing that you now can get an effect by manipulating the microglia as well. Okay? But this is basically how you respond locally to what happens in brain in terms of activity. And then the final is this autoregulatory concept. So there's a large window, and most of us should live, this is mean arterial pressure, but should live most of our lives between 50 and 150, right? Okay. Most of you don't want to have your blood pressure outside of either of those ranges. And during that, the cerebral blood flow is normally maintained as a flat blood flow. Okay? So that you can have massive fluctuations in blood pressure without problems in brain perfusion. If the blood pressure goes up, the system cannot dilate more than it needs to, enough to compensate for it, and perfusion will go up. That's a problem because in the setting of some types of cerebral ischemia, blood pressure goes up. Anybody know what that reflex is called from cardiovascular? Cushing reflex, okay? So your blood pressure goes up as intracranial pressure goes up, partially perhaps in an attempt to perfuse, but if it goes up too much and you're bleeding and you're now unable to compensate, you run the risk of increased bleeding. So the goal is usually to maintain pressure at this point or below. And if your pressure goes down, there's nothing that vasodilation can do. If you've got, blood pressure, mean arterial pressure of 30 millimeters of mercury, that you can't dilate enough to get it into the head, okay? This is actually a dynamic system, and it turns out that the best modulator of it is CO2. So in fact, if you do somebody, and this is end-tidal CO2 volume, so you can actually change cerebral blood flow by retaining CO2. So you can change the shape of this dynamic relationship, and you can actually shift the flat part of the curve upwards by increasing CO2. And the ability to do that is a marker of the ability of the vasculature to respond. And so that can often be used as the physiologic assay, because it's pretty easy to get people to increase their end tidal CO2. What do? Yeah, you rebreathe. So paper bag, anything where you rebreathe in with high CO2 increases your overall CO2 concentration transiently. So you can look at perfusion that way. Okay. So those are the sort of external concepts that are going to apply to the entire vascular system. But now let's go and remember at the very beginning I said there are the 40% of your vascular resistance lies in the big named vessels. So let's name them. Okay? So we're talking about perfusion that comes from the heart, from the left side, off the aortic arch. And we looked at this graph picture before when we focused on the two vertebral arteries. But right now what I want to think about is not just the two vertebrals, which come off the subclavians, but the two carotids, one of which comes off the common carotid, the other comes off the subclavian, as the two common carotids that bifurcate, okay, with the externals going out, up, and more anteriorly, and the internals coming up and entering the skull at the base through the cavernous sinus, okay? So on each side, we have two vessels that bring blood in. We've already talked about the two on the basal. We talked about two vertebrals that come in. And then I'm going to draw two carotids here. Okay? And what we're going to do is basically make one large anastomotic structure at the base of the brain that will have the source of all other vessels. Okay? So we know that the vertebrals come up, and then as we saw, what do? Everybody's moving their hands. Somebody has to be able to put words, say words to go with these images. Yeah, they come together where? On the left or the right? On the midline, right? Okay? So they come together on the midline. And now we have a new name for the vessel, and what is this? The basilar. All right. So let's name some things that come off the vertebrals. Okay, so we've got pica. Anything else? Anterior spinal, exactly. So we've got an anterior spinal that comes back like this and descends. And I'm going to draw in arrows that indicate directionality here. Okay? Now, what else do we know comes off the basilar that has a name? There are lots of things that come off the basilars that don't have names, but what's the next one that has the name? Okay, so let's say the ica. And then? Well, yeah, there are lots of pontine paramedian penetrators, but something big. So, posterior cerebral. And we have one on either side. Anything else? Yes. Somebody? Louder? Superior cerebellar. And let's think about landmarks. What sits between the superior cerebellar and the posterior cerebral? First of all, where's the top of the basilar origin of the posterior cerebral? Midbrain, pons, medulla. Midbrain, right? Because remember that top of the basilar syndrome leads to oculomotor disturbance, peduncular hallucinosis. So if it says peduncle, it should be up by the cerebral peduncles. Okay. And where's the superior cerebellar? Midbrain, pons, medulla. Yeah, very top end of the pons. So what cranial nerve sits between the medulla and the top end of the pons? Yeah, remember, this is the ventral surface, right? All of this is happening on the ventral surface. Why is it happening on the ventral surface? Because that's where it is. But no, but think about it. Where do the blood vessels come into the skull? Yeah, they come in at the base, right? I mean, they don't come in, they don't run up along the outside of the scalp here and then enter. They come right up from the base. So all of these vessels feed from the base. Okay? So this is the ventral surface. So 4 is on the dorsal surface, so it's not likely to be 4. So it could be, yeah, so 3, in fact, sits here and here. All right? So this is 3. This is superior cerebellar artery. This is ICA. This is pica. And this is posterior cerebral artery. And these are my 2 internal carotids. All right. So we've got that posterior circulation that we already covered. Okay? So where are they coming into the skull? All right. Well, here's the vertebral coming in back here in the posterior fossa. Remember, does the vertebral come in through the foramen magnum? No. It is lateral on either side, and there's a single foramen for the vertebral artery. Okay? So the vertebral artery comes there. The carotid comes in through the cavernous sinus. Where's the cavernous sinus going to open up? Which fossa? Middle, right? Comes in at the middle. What's lateral to the cavernous sinus? Underneath the dura? In a cave? Yeah, Meckel's cave. Who lives in Meckel's cave? Trigeminal ganglia. Okay, where's the trigeminal ganglia? Meckel's cave. Thank you. All right, it's in that medialmost wall of the middle fossa. Okay, right there, so that the V1 can go out through the superior orbital fissure, V2 through the round window, V3 through the oval window, right along that medial edge of the middle fossa. Okay, medial to the temporal lobe. Okay? So the carotid is right there. All right. So here, as we've seen, we've got the posterior spinals that go on the back, but we've got the anterior spinal bridged from the 2 vertebrals, and the vertebrals coming to the basilar. And when we think about cord, so I'll show you in a moment, we will have our anterior spinal corresponding to the vast majority of cord, usually up to the midpoint in the dorsal gray matter, the dorsal columns being here, the anterior horn, the dorsal horns coming like so, the anterior horn, and so, with that being the posterior spinal territory, but all of this, both anterior horns, both lateral corticospinal tracts, both anterolateral systems being covered by the anterior spinal artery. Okay? Oh, picture right here. Okay? So the posterior, in fact, here is drawn reaching to corticospinals. It often doesn't. It often peters out right around the edge of the dorsal gray matter. All right, so as we think about them lying on the pons, okay, the basilar lies on the pons. At the upper end, we have the superior cerebellar. In between, then comes the third, and then the posterior cerebral coming around. We have ICA going to this small zone medial-laterally on the ventral surface of the cerebellum, while most of the inferior surface is covered by pica, and the superior surface will be covered by the superior cerebellar. Where are they? Well, here's vertebral. It's hard to see the branch that comes down to make the anterior spinal. Here is the basilar right along the midline. Here is a carotid stump right here. Here is the other carotid stump. Then we can't even see the posterior cerebral or the superior cerebellar easily. What's this? Oculomotor. What's this? That's 4. Notice it's coming from around from the dorsal surface right there. All right. Here's the stump of big fat cranial nerve lateral in the mid-pons. Got to be 5. Okay? Here's 3. Here's 3, 4. It's hard to see on this side. What's this right here? And here? 6. So that's 3, 4, 6. That's got to be 5. What's over here? 7 and 8. Yeah. I mean, it's 2.5 weeks ago, but you can't forget it. Okay? All right. So here's where they are relative to those nerves. So when we look laterally, we see pica coming around. It serves as the circumferential branch for the medulla, and it goes and it's going to hit that entire inferior surface. Ica just comes to this lateral aspect, and the superior cerebellar coming around and doing the same thing both to the colliculus and then going on to the cerebellum as well. So as you look, we see essentially a territory that separates out like this being all pica, that being all superior cerebellar, and Ica being a little zone in here, and that's about it, okay? So that when you look at the boundary zone, it will be out at the lateral edge all the way around that cerebellum, okay? That's the boundary between one vascular territory and another. It's the area that's most at risk in hypoperfusion. So when we look and we go through the brainstem, and this should be review, we've got this concept of paramedian, short circumferential, and long circumferential, basically creating zones in these structures, sort of 3 pi wedges, each of which is vulnerable, and each of which will bring with it a set of structures. So the paramedians here, loss of this will give us what? If we lose this and this. And this is on the right side. You lose your right pyramidal tract, what do you lose? Left-sided motor function from where? Well, how's moving your face? Yeah, so at this point you're below the 12th cranial nerve. Almost all of your face is going to be intact except for maybe what? What's lower? What's lower than 12? 11, right? So 11, where are the motor neurons for 11? Spinal cord, okay? So you might well have some neck weakness, some shoulder shrug weakness, but you'd move your tongue fine, you'd move your mouth, all of that would be intact, okay? And then what else would you lose? Yeah, you'd lose your lemniscal, proprioceptive, light touch, vibratory information from where? Left or right? Left. Okay, it's already crossed at this point. If it comes, how about pain? Pain from your foot? No, that's already way out over here, right? That's over here. So you're not going to lose that. That different vascular beds. Okay? Same thing as you come up. Where are we now? Yeah, we're still in the medulla. Higher or lower? Higher. What's the clue? Well, there's olive here. Yeah, cochlear nuclei. Remember, cochlear nuclei bridge medulla and pons. So if you see them, you're higher up in the medulla. Okay, where are we? Pons. High up or low? Okay, what's the clue? Bunch of them. Yeah, middle cerebellar peduncle. How about shape of the 4th floor of the 4th ventricle? It's not tapering down. Okay. You also still see some of the vestibular complex up there, out laterally. Higher up, where are we? Midbrain, okay? But now, if you have something that gives you a sensory deficit, such as hitting out here, will it give you a sensory deficit in all modalities? Yes, right? On the contralateral side. And would it involve the face now? Yes, because you're well above the point where those facial fibers came in. Okay. All right. I mentioned the top of the basilar syndrome last time. Very concept of the idea of the top. So when we get to the top of the basilar, we're at a boundary. All of this is called posterior circulation. Everything in front, therefore, is known as anterior circulation. and the two are connected by communicating arteries. So that's the next concept, is that there are communicating arteries. How many of them? So I have two. How many for two? How many for four? Well, the average is correct. It's actually three. Okay? Why? We have a posterior communicator on either side, and we know that we made essentially a communication between the left and the right in the posterior circulation by doing two vertebrals together to one basilar. We've got two carotids coming in. And what are we going to do? We're going to connect the anterior half as well. But we're only going to have to make one vessel to connect left to right. So there's one anterior communicator and two posterior communicators, and that will make a circle. Okay? So we've got an anterior circulation, which is connected to the posterior circulation by the posterior communicating artery. It is a small branch that connects, what's this vessel? It's labeled for you, but you should know it. It comes right at the top of the basilar. So posterior cerebral, PCA. This is internal carotid, and this is the posterior communicator. It is usually smaller than either the vessel it feeds from, the carotid, or the vessel it feeds into, the posterior cerebral. In development, early in embryology and even up into fetal life and at postnatal periods, they are all roughly the same size. In some people, that vessel stays large, and that's known as a persistent fetal circulation, which is odd for nomenclature, because you would think that something that was persistently fetal would be small. But in fact, it means a large one. It is the persistent fetal pattern, not fetal size. Okay? And there's a lot of variation in the way those posterior communicators sit. So where would that be? Can you see it? Well, here's your carotid. It's mostly hidden. All of its branches are pretty hidden. But this, right there, and here, is the posterior communicator. Okay? They run posteriorly. They run along the basal surface of the brain, heading towards the lateral aspects of the midbrain, where they can anastomose into the posterior cerebral artery. So when we think about that, and the brainstem is sort of pushed back, you can't see this. You can't see this. What's been done is essentially to put a lot of traction here. So normally, the basis pontis is in the way, hiding the mammillary bodies in the light. Okay? So we've got our carotids and our basilar, and we've got, therefore, the posterior cerebral and the posterior cerebral. We've got the third nerve peeking between the posterior cerebral and the superior cerebellar. And so now we've got a right circulation and a left circulation, so a carotid on the left and a carotid on the right. And we have a posterior communicator that runs here to here and joins, and here to here and joins. Okay? And then we're going to have something that runs anteriorly. We have an anterior cerebral that comes off, and an anterior cerebral that comes off, and it comes close to the midline. There is one anterior communicator that joins them. So three communicating arteries. The anterior communicator is very short. It actually has an incredibly high probability for its length of having an aneurysm, because it's one of the relatively common sites for aneurysms in the vasculature, in the cerebral vasculature. And together we have an anastomotic circle, okay? So that we can, if we think about posterior cerebrals, communicators, carotids, anterior cerebrals, and anterior communicators, it makes a loop. So that you can, in a sense, if your circle is intact, you don't have atherosclerosis on it any place, you don't have an absent vessel, which is a pretty common variant, if this vessel is clogged, you can still get some blood that comes from this carotid around, and in fact you can maintain adequate perfusion pressure in the contralateral, on the same side in the posterior cerebral, because this is an anastomotic circle. So blood will flow depending on pressure gradients not in a fixed unidirectional manner. So while I can say that in the vertebral, the direction of flow is from the base of the skull inwards, I can't be sure which direction blood flow in a posterior cerebral is going. Okay? Depending on your anatomy, depending on fixed lesions, it could be dependent more on the carotid, the way it usually is, but it could be dependent more on the basilar. Okay? So when we think about aneurysms, these are in basically multiple, there are several types. The most common and what we think about as so-called berry aneurysms, or are in fact congenital arterial wall defects. They're not acquired. They grow over time as pressure and injury to the vessel wall progresses, but they are an intrinsic abnormality in the muscularis of the vessel. They tend to increase over size, and the risk of bleeding, of rupture, is proportional to size. Greater than a 1 centimeter aneurysm carries an approximate 50% annual risk of bleeding. Okay? That's a pretty big risk of bleeding. The estimated death rate, mortality rate for an aneurysmal bleed is about 20-25%. Okay? So that's a really high risk of dying in a year if you have an aneurysm of that size. Okay? So they are ideally treated when they are smaller. They can be treated either by going in and putting a metal clip right across the base so that you get rid of the aneurysm and its propensity to rupture. They can be treated endovascularly by threading a catheter and shooting a coil that is thrombogenic into them. They can be treated by basically putting diverting stents that change and shape flow so that there's no flow here. They don't have flow, they tend to thrombose. There are a variety of methods that are used, but they are a major issue in terms of sort of detection and treatment. And the major association that you need to remember? Board's question. Polycystic, what type? Adult onset polycystic kidney disease and aneurysms, multiple aneurysms.
I was curious, how do you access this area surgically through the foot?
With a big craniotomy and a lot of trauma into the brain. That's why endovascular is preferential much of the time. It's not easy to get to because they are down on the base. Okay? In general, this one has slightly odd numbers, but roughly 90% are in the anterior circulation, 10% are in the posterior circulation, and it's roughly a third. Anterior communicator, internal carotid, proximal middle cerebral. Okay? Just remember them. That's sort of those are the standard answers when you're asked that question. Polycystic kidney disease, greater than 1 centimeter is 50%, a third of the anterior, and the last 10% are in the posterior. What do they look like? Well, here's one right on the anterior communicator. This is a CT reconstruction. Bulging right there is that aneurysm. If you want to see that aneurysm for real, this is the person died. That was tried to be treated with coiling. So here's the circle of Willis dissected off the brain. Okay? So you can see everything we need to see. This would be internal carotid, and this bent over here is the internal carotid. This is the basilar. Look at this. What does this person have? Only one vert. But the vert is the same size as the basilar. So developmentally, they have only one vertebral artery, and they lived off of it, and in fact, it gave rise to both picas. That's the other pica. This is the pica that went to this side. Okay? It gave rise to both, and that's the way their vascular anatomy was. Normally, the vertebral is smaller than the basilar. Here, it's the same size. Okay? What's this? Posterior communicator. What's this? A massive posterior communicator. They didn't have a vert on that side. They have a big posterior communicator. Okay? How about this? Yeah, that's posterior cerebral. And this? Superior cerebellar. Okay? So notice, on this side, here's this huge posterior cerebral artery, and on this side it's a big posterior cerebral. On this side, it's mostly supplied by the basilar, and on this side, it's mostly supplied by the carotid. Okay? Here are the beginning branches of the anterior cerebrals. These are the middles. And here's where they come together. Here's the anterior cerebral here, and the anterior cerebral here, and right here is the communicator, and right there is the aneurysm. And if you look at it, you can actually see that it's packed with metal. But it's kept bleeding in this patient, and that's why they died. This person had two massive aneurysms, one here, which is collapsed on one internal carotid, and this one, what's happened? What is that? Looks like currant jelly. What is it? Clot. Is it on the inside of the vessel? Oh, it's on the outside of the vessel. This is a ruptured aneurysm that killed this person. Okay. So, when we think about the circle, we've got carotids and the basilar. We've got the communication of the two posterior cerebrals that come into the two posterior communicators that come into the posterior cerebrals. The two anterior cerebrals that come together just sort of kiss at the midline with this very short anterior communicator. And then we've got the anterior cerebrals that continue. Okay? So, when we think about them, and these are the big three that you need to know next. So, beyond, when we're in the anterior circulation, there are essentially three we need to think about. They're the anterior cerebral, and we name them A1 and A2. That's not the left and the right, but rather the first segment, so from the carotid going out, before you get to the anterior communicator is A1, and then after the communicator is A2. Okay? That's a way to know about describing a location. Okay? When we think about the middle cerebral, we have an M1 and an M2, but there's not a communicator here. It's the first segment up to the main branch point where we have the so-called anterior and posterior divisions, sometimes called superficial and deep, but I prefer anterior and posterior because they tell you where they go. And beyond that, you now have got M2 branches, whereas before it you had M1 branch. Okay? And then we've got posterior cerebral, which again has a P1 and a P2. And that one's named the same way that the anterior is. From the basilar to the entry point to the posterior communicator is P1, and then beyond it is P2. Okay? So those are the nomenclature that you need to know roughly in order to be able to talk about locations. Okay? So let's think about what they do. So here, where's the brain been cut? Yeah, it's cut across the midbrain. Why? What do you want to see? If you want to see the posterior cerebral, it begins here, and then it's hidden normally. Remember, the midbrain would be here, the cerebellum would be sitting here, okay? But here's the vessel. You can't see it unless you get all of that brain out of the way. Does that sit on the supratentorial or infratentorial surface? Okay? It is above the tentorium. It is on the cerebral hemisphere surface, which puts it above the tentorium. The superior cerebellar? Below the tentorium. Okay? Right? Has to be. Where's the cerebellum? Below the tentorium. So that's where its vessels have to be. Okay? So we are looking as though we are the tentorium, the top leaflet, and we're standing on the top leaflet looking up at the brain, and there it is. Here's the posterior cerebral. This is the posterior communicator. And look, where does it run? Loops around to the tip of the... What's this? Yeah, it's temporal tip. Where is this? What is this? What surface? I mean, if I asked you to say, you have put a recording electrode here, what part of the brain are you in? Prefrontal cortex? Orbitofrontal cortex? Yeah, inferior temporal lobe? Yeah, okay. It's not that hard. Okay? Really isn't. Okay? Back here? Any ballpark? Is superior or inferior? Inferior surface of what, probably? At this point, we're probably in parietal lobe. How about here? What am I going to be coming into? What sort of type of cortex? Yeah, occipital. We're sort of on posterior, medial, inferior visual cortex. It's probably a visual association area. So we're thinking about all of this surface out here, basically where you can see those vessels. That's what it's supplying. Okay? These are the peel arteries and arterioles from their branches that will then be going on to the penetrating arterioles that are the ones that are responsible for the neurovascular unit dynamic response. Okay? Can you see the other arteries? Well, you can see the stump of the carotid. You can't see the middle cerebral. Why not? It's shadowed here because it is between, frontal and temporal. Where is it running? What sits between the frontal and the temporal lobes there? Sylvian fissure. Okay. How about the anterior cerebral? What structure is it hidden above here? Because we're looking from the base. This is the optic chiasm. So it loops right underneath the very boundary, or above, right above, because we're looking at it from below. Right above the very boundary between the optic nerve and the chiasm, comes right to the midline. And what is it? Where is it here? What if I were to make the cut here and open that, what would you be looking at? Medial or lateral surface of frontal lobe. You'd be looking at the medial frontal lobe. Okay? And where is it going to run? It's going to run right along that medial frontal and medial surface all the way posteriorly, while the middle cerebral is going to traverse out the Sylvian fissure and run out laterally. So each one of them, if you cut the brain in the appropriate manner or view the brain in the appropriate manner, you see not only the vessel, but its territory. Okay? So this is the way you see the territory of the posterior cerebral. So what are we looking at now? Which vessels? I labeled them. I circled them. I'll draw your attention to them in blue. Okay? We're looking at the medial surface. So that posterior cerebral runs around that medial inferior surface of the temporal lobe, parietal lobe, into the occipital lobe. Okay? What vascular territory does the primary visual cortex lie in? Where's primary visual cortex here? Yeah, everybody's going like this, right? Which is anterior. Where do I need to move to get to the primary visual cortex? First, I need to move on to the brain. Give me anatomic landmarks. Posterior. I'm still not on the brain, so it would be great to get me onto the brain. Inferior. Yeah. What vascular territory am I in? Posterior cerebral. It's the medial surface of the occipital lobe. Okay? That's where it is. So what happens if you have a posterior cerebral territory infarct? In the left hemisphere, which is what this is, what do you lose? Right visual fields. That whole right side of the world you've lost. Okay? Now, we can also see the anterior cerebral. Remember, we saw it looping around, coming from the carotid down here, coming across. Here it is, running on the medial surface. Okay? Down here, what would this be? Sort of this. Right here. This is olfactory bulb, the gyrus right above it. Gyrus rectus. This is orbitofrontal cortex, right? Branches of the anterior cerebral there, running all along the medial aspect. This right here is the Corpus callosum, the cingulate, which we'll come to on Friday, is right above it here. Okay? And the medial surface. What's right up here? Yeah, central sulcus. So in that vascular territory of the anterior cerebral, what part of motor cortex is there? Primary motor cortex for what part of the body? Let me get more specific. Fingers? Toes? Yeah, your leg. Remember, your hip lies roughly at the top. So the hip is there. So occlusion there on the left side, what would you expect is a motor deficit? This is the left side, so you'd expect right-sided, probably maybe from the hip flexors and extensors downward weakness. Would it come with sensory abnormalities? Yeah, because the sensory, this runs back into the parietal lobe, almost all the way back to the parieto-occipital notch. So you'd expect to have comparable sensory deficits. Which modality? Vibratory? Yes. Pain? All modalities? Yes, because you're talking about somatosensory cortex. Where are they separate? From about the mid-pons downward. Once you get to the mid-pons upward, they're next to each other. They're next to each other in the thalamus. They're next to each other in the cortex. They're, in fact, in the same vascular territory. And now, here are the branches of the middle cerebral arching out of the Sylvian fissure and supplying what's both above and below it, which will include this region out here. Where's my pen? This region out here, what is this? Dorsolateral prefrontal cortex. In here. Frontal eye fields. In here. Supplemental motor. Here. Motor. So Brodmann area 4. Here. Yeah, somatosensory. 312. What parts of the body? From about the hip upward. Down, including face. What sits right here? We're looking at the left hemisphere. Broca. Okay. What sits back here? Wernicke. What sits in here on the superior temporal gyrus horizontally? Auditory cortex. Left hemisphere. Which ear do you lose hearing in? You don't lose hearing at all. Hearing has scrambled itself left and right in the pons. Okay? Okay? But your other deficits will be unilateral, and we'll tell you something. It's, in many ways, it's a whole lot worse to have your big middle cerebral artery stroke on the left than the right. Because you have it on the left, you get motor deficits and sensory deficits that are comparable, left side versus right side. If it happens on the left, you also have the language deficits that go with it. Okay? They're essentially the motor planning area for volitional eye movements, the same way that you have the supplemental areas for other volitional movements. Okay. Now, notice that there are going to be boundaries between these. Those boundaries are going to be areas that are vulnerable to hypoperfusion in the setting of low blood pressure, where you can't auto-regulate. In the setting of hypoxia, where you're pumping, but your blood oxygen contention is not high enough. In the setting of hypoglycemia, where you're delivering blood and oxygen, but your blood glucose is 6 instead of 126. Okay? So those are areas that are vulnerable in those settings. And here's the really ugly thing. None of the territories and none of the boundaries map onto functional areas. So in fact, if you look, stroke deficits will cross functional domains that are highlighted for us in the Brodmann map at the bottom. And so we will get deficits that will cross domains. There will be some motor and some sensory in a part of the body, but not necessarily in all parts of the body. Okay? You will have visual field cuts, okay, in part, but not in both sides, okay, because that information is separate. You usually don't get auditory deficit in the sense of hearing loss, but you can get language processing and so on, okay? And I have to say, I hate this figure, but it's one of the few ones that I have. I think the boundaries here, the middle cerebral artery territory is usually much higher up. It is much bigger. And so much more of the lateral aspects looks like that. How about middle cerebral artery territory on the medial surface? Essentially none. The medial surface, if you take a hemisphere, you've got them in the lab, pick the hemisphere up. The lateral aspect, what your hand touches, is the middle cerebral artery. What your hand touches on the medial aspect, in the fingertips, in the front, is the anterior cerebral, and the pad of your hand is the posterior cerebral, okay? And if you can just remember your hands on the brain like that, you will keep those cerebral artery territories straight, okay? Assuming that you're left-handed and pick up a left hemisphere. Okay. So those boundaries, remember they are not watersheds, because they are the distal most portion, they're not the source from which blood, oxygen, and glucose arrive, will sit. So we can think about what sort of deficits we'll get when we get those boundary zone infarcts, okay? This book calls them watershed, but they're boundary zones, okay? So let's think about them. What are you going to get? And this is called, if you have hypoperfusion, let's think about this happening in the zone of the motor cortex and sensory cortices. What's there? Well, let's draw the homunculus onto the brain. Remember remember our little friendly homunculus? Okay? Got the medial surface. You're going to put your toes down here. Okay? You're going to put your hip, so your knee, your thigh, your hip here, and then hanging over the lateral aspect here, you've got your trunk, your hand with huge fingers, and then your head with a huge tongue, right? That's the homunculus. So what happens if you take out this segment that sort of sits? What gyrus is there that's sort of hatched out? Tell me. So if we think about them, we've got what's this? Insula. So that makes this frontal lobe, right? So we've probably got superior, middle, and inferior frontal gyri. So the lesion is at the boundary between the superior frontal gyrus and the middle frontal gyrus. What part of the body is represented roughly there? Yeah, trunk. Sort of mid, thorax and the like. And that's sometimes what gives this so-called man-in-the-barrel syndrome, where things above the barrel are intact, your arms, your face, your head. Things below it, hip flexors and extensors and lower extremities are intact, but there's a motor and sensory disturbance in the thorax and upper abdomen, okay? What's out here? Think about this boundary between middle on the lateral aspect and posterior, okay? This is a horizontal. What's going on out here? Yeah, it's what stream? There are two streams, remember? Yeah, I showed the picture to you like this, but now you got to roll it over in your head. So remember, there's your visual processing, and you've got a dorsal stream and a ventral stream, and this is much more about the what. Remember your prosopagnosia, your facial recognition area, the word areas that are responsible for semantic dementias, and then this is the where, which comes together with your auditory information about space and your somatosensory. This thing looks like a sick whale here. Okay? But that's the where stream. So you lose this ability to do higher order visual processing about spatial orientation. Okay? Here's that somatotopic map again. Okay. So, yeah, you lose a lot of white matter. Depends. So, yes, and does white matter matter? It doesn't have neurons in it. Well, who cares, right? No, so you get a lot of deficits, and it depends how deep they are. And it depends on the vascular territory of the deep white matter is usually the last portion affected in these. So we think about these. Superior left MCA, okay? This is the so-called anterior. What's in there? When the chart tells you, but tell me what structures are in there. Which way do you expect your eyes to deviate? This is on the left side. Your eyes should look to the left, because your right eye fields is still driving them, but you lost your left eye fields. Okay? So your eyes should look to the left. Which side should be weak? The right side. What part of the body should it involve? Whole body? If you have the whole body involved, where is it most likely to be? Where do you have everything together? In the, well, pyramids, or in the peduncle, mid-portion of the peduncle, or even in the posterior limb, but not up in the cortex. They're spread in vast cephalovascular territories. So what part of the body? Says it. Can you read? Face, arm, okay? All of the face? Yeah, except the forehead. How come? Because the forehead motor neurons in what nucleus? Facial nerve nucleus are innervated by both cerebral cortices. Okay? And you would have the language. You'd have a Broca's aphasia there. Okay? If it was just the posterior division, okay? Now you're getting more sensory disturbance, visuospatial, okay? You're going to get right-sided neglect. Lost left parietal lobe? No, remember, the right side of the world, both hemispheres pay attention to. Okay? You get left-sided neglect with a right parietal lesion, but not the reverse usually. Okay? How about language? More of a Wernicke's. You've taken out those posterior ones that create not the output device, but the content components. Okay? Argentinian rifle. Okay? Remember. Okay? You might have some weakness, especially early on as it swells and compresses. Okay? How about on the right side? Would basically be the mirror image, except you would not get the language disturbances. Okay? In general, it means that people are far more aggressive in trying to salvage people with massive, devastating right-sided strokes, middle cerebral artery strokes, than left-sided, because the quality of life in people with significant left-sided strokes can be really quite poor. And the same thing is true for the inferior division on the right. The anterior cerebral. These are somewhat more subtle often. But remember, the anterior cerebral, what part of motor function and sensory function is likely to be disrupted? Part that's on what surface? Anterior cerebral is medial, mostly frontal, and coming back into parietal. So what are you going to get? Leg, lower extremity, motor, and some sensory. Are you going to have a lot of visuospatial disturbances? No. Okay? You're not really out there in that lateral portion of parietal lobe where that wet dorsal stream is running. Okay? Contralaterally on the right hemisphere, you get it on the left. If you do it in the posterior, the visual field cuts are the most easily detected and most pronounced. Okay? And they are contralateral homonymous hemianopsias. Okay. So, anterior and posterior circulations connected by the communicators. Let's stop at this point, and then we'll start to dive deep, and we'll track the vessels that go to thalamus and basal ganglia. Let's pick up again at 1/4 of. Let's get back going. All right. So we've done the easy stuff. And we've done what makes them easy is, first of all, there were really only 3 big cerebral arteries, anterior, middle, and posterior. And once you sort of visualize where they lie, you can see their vascular territory. And now we know underneath them, there's more stuff. It's not just the cortex, right? What's underneath it? What's underneath cortex? White matter. And what else is down there that we spent, a couple of days talking about? Thalamus. Anything else? Anybody who was here Friday? Anybody who was here and awake Friday? Basal ganglia, right? Do they need blood? Yeah, okay. So how are they going to get blood? We now have to follow vessels someplace off these external structures and follow them deep, okay? And that's the next task. So where are those surface vessels? Okay. Here is our carotids. Posterior communicator. Running out here where you can't see it. And here. Middle cerebral. Running out here where you can't see it. Posterior cerebral. Running here. The anterior cerebrals. Okay. So, which ones do we think? Now, roughly, here's this brain. If I asked you to take a large skewer and shove it in from the surface here and make sure you were going to hit the head of the caudate, where would you put it? Yeah, fingers are wiggling. It's like I'm asking you to touch your nose with your finger, okay? I see the fingers going. Let me put I'm going to start with my skewer right here at the cut surface of the spinal cord. Tell me where to move. Anterior. I'm staying on the midline here. Lateral, okay, I'll go this way. Yeah, I would go right about here. What blood vessel's closest going to be to us here? Middle cerebral, okay? There's going to be a little trick to this, but middle cerebral. Where's the thalamus relative to the caudate? Medial or lateral? Visualize it. Think in your head. The brain is lying in front of you, okay, in a coronal slab, cut like this. You've got caudate, putamen, accumbens, and the anterior limb of the capsule. You now move posterior. What are you going to come to? Thalamus, thank you. Okay? Now where's the thalamus going to sit? Okay? Posterior. But what part of capsule? Posterior limb of the capsule, remember? Okay. Posterior limb of the capsule sits where? Between thalamus and putamen. So it's going to be, and it's going to extend quite far lateral, as well as having, what's the sort of medial-most portion of the thalamus going to be? And anterior? 2 nuclei? I gave you both names just there. Anterior nucleus of the thalamus sits where? Anatomic landmark for it? Foramen of Monroe. Okay, foramen of Monroe is right off the midline. It's where the third ventricle connects, okay? And then what else is along the midline in the thalamus that matters a lot? Dorsomedial. Okay. But how about things like pulvinar? Way posterior and pretty lateral. Remember, the thalamus makes that angle. It's an angled oblate. Okay? So we're going to have to get things that are pretty far posterior and lateral. Back out here. So if I were to sketch it, I would say that the thalamus, if I were to go in deep, would be back like this. The caudate would be like this. And the putamen would be like that. So what vessels do you think we're going to feed the thalamus from? Posterior cerebral, and what else maybe? Posterior communicator. Gee, neuroanatomy makes sense if you think about it. Once you've got the objects in your head, it can sort of begin to make sense. All right? So, here's the most bizarre picture of vasculature and thalami you're ever going to see, but it's the best one I can find, and it comes from the classic paper on the thalamic stroke syndrome. So what do you think vessel 1 is? So here in panel A, vessel 1. There's also vessel 1 that's up here. That's my internal carotid stump right there. Okay? So 1 is my internal carotid. What is 5? Yeah, it's my posterior communicator. PCOM. So what is 2? P what? P1. Okay? And here, coming around further, if this is my top of the basilar here, and this is my posterior P1, this is my posterior communicator, this is my P2. And that's the segmental source of the vasculature for the thalamus. Just the way you see it line up when you figure out where it is on the brain. So this is why when you get back into lab this morning, take those hemispheres that are cut, stack them up, see where you'd mark off each of those vascular territories, and then open them up and peek inside and see whether you find what you expect underneath. Okay? So what are we going to have if we have sort of 4 segments here that come from posterior communicator, typically then the P1 and then P2 segments, okay? So what's going to be in this anterior-most portion of thalamus? What type of function? Motor. You move a little further back? Somatosensory. You move further back so you come back into the pulvinar? Yeah, scared of snakes. Visuospatial. All of that visual spatial organization, okay? What's at the very posterior end of the thalamus? The geniculate. What are you going to lose when you lose them? Vision from the lateral, and how about from the medial? Auditory information to one side of cortex, but you're not going to lose information about hearing, okay? So, when we think about the first one, it comes from the posterior communicator and it's more anterior. This tends to give you neuropsych and cognitive dysfunction. Where's that coming from? Yeah, that's coming from dorsomedial and the anterior that go to the prefrontal and cingulate. Also gives you some language. Neglect. If you get a right-sided lesion, you can get some neglect. But anterior, you usually don't get as much motor and sensory if it's very anterior. You come to the next one, and you're hitting more of ventrolateral. Okay? It's mostly from the posterior communicator still. You get cognitive stuff. Hemiparesis. You've lost the thalamus, bringing all your motor into cortex. So these are thalamic strokes, small end artery embolic lesions that can take that out, can give you as much of a deficit as both a middle cerebral and an anterior cerebral in terms of the motor loss. Depending on how far the boundary is, you can have sensory disturbances. And why might you have hemiataxia? Well, what's the VL part of thalamus really getting on its way to cortex? Cerebellum. So to the extent that you still have any motor strength left, okay, you will be ataxic with it, because you're not able to use cerebellar information anymore. And oculomotor, because you've got muscle information going from there up to the eye fields. Let's step a little further back and hit one that's the so-called infralateral, which is a posterior cerebral branch, okay, typically off P2, okay, and that's going to hit mostly VPL, VPM. What are you going to get? Sensory disturbances, hemisensory disturbances. Hemi because they're hitting the thalamus where these things are really close together, unlike the cortex where leg and foot and hand are far apart again, okay? In the thalamus, they're within a centimeter of each other. In the cortical ribbon, they're 6 centimeters apart in separate vascular territories. Usually not much weakness, some less cognitive stuff because you're not mostly supplying the things that project to prefrontal cortex, but you often get pain. And this is really bad pain for which there are really no effective treatments, okay? This is known as thalamic pain syndrome or central pain syndrome or Dejerine-Roussy syndrome, okay? So these are Dejerine and Roussy. Who named it? Dejerine is shown with his wife. Anybody know what his wife described? Look at her name. Yeah, Klumpke's palsy. Okay? Remember, there are two brachial plexus injuries associated typically with traumatic birth. Klumpke's, which is the lower brachial nerve lesions with the hand turned up and in and rolled in. And the other is Erb's down and out like this. Okay? Upper brachial plexus injury. She actually had been in a habit once frequent but now frowned upon. She'd been Desjardins' student before she became his wife. But there she is. She was also a relatively well-established neuroanatomist, focused much more on brachial plexus and peripheral nerve than central. Posterior choroidal. This comes off the posterior cerebral. If it's called posterior choroidal, where do you think it's headed? Choroid plexus, because you need to supply blood supply to the choroid plexus, because basically the generation of CSF is a direct filtrate by the choroid plexus of blood. If you don't perfuse it, you don't make CSF. Okay? And what do you hit? It hits pulvinar and the geniculates, so you get visual and oculomotor disturbances. You can sometimes get field cuts if you hit the lateral geniculate. Sensory changes are pretty minimal because it's mostly well behind the VPL, VPM. Okay? So it makes sense based on where it is. It's posterior communicator and posterior cerebral, small distal branches. If you lose the whole posterior cerebral, you will lose what? You'll lose its cortical surface territory on that medial surface of the inferior temporal, lateral inferior surface of the temporal lobe, parietal lobe, occipital lobe, medial occipital lobe, some medial parietal lobe. You'll lose the underlying white matter, but you'll also lose a significant portion of thalamus. Okay? So big full territory infarct gives you one. Small little embolic lesion can pick off just the vessels that go to the thalamus. Okay? Now let's think about caudate and putamen. And if we go back to that schematic where I asked you to guess where they were, where did we put them? More anterior. Okay? So we're not likely to be coming off posterior communicator or posterior cerebral. We think we should be much more off internal carotid middle cerebral. And in fact, we are. Okay? So we will see that some comes from the posterior cerebrals back here, but much more of it, that's going to be the posterior portion. Remember, the caudate comes all the way around from the head to the body and the tail. And where's this tail? What lobe of the brain would you find it in? Temporal lobe, right? Sits on the roof of the temporal horn of the ventricle. Okay? Temporal horn of the ventricle is going to be located in the temporal lobe. Okay. So we've got it back all the way back there. The caudate runs like that. But much of it is going to be fed right off the top of the carotid, right here, with these lateral striate. What is striate? For the striatum. Okay. So where are those vessels? Okay. So we've got lenticulostriates. Okay. We've got the choroidals. We've got the where am I? So we've got the choroid, we've got the lenticulostriates and the anterior choroidals that are visualized there, and then we've got the anterior perforators in here. We'll see in a sec. Okay. So when we think about where they are, this is a brain cut in a really funny way. So what's been done is you can see the optic tract and you can see the choroid plexus. So you've cut into what here? Cut right across into the temporal lobe. This is the choroid plexus in the temporal horn of the lateral ventricle. Okay? Okay? So you're looking into the ventricle here. Okay? Here is your posterior choroidal vessel. Remember, coming off the posterior cerebral. Okay? That's in the posterior part of the choroid plexus. In the anterior part, we have the anterior choroidal that comes typically off the initial portion of the middle cerebral or the top of the internal carotid. Okay? Along the way, we're going to be able to have branches that are going to come in to basal ganglia below. Here, we've got these lenticulostriates. They're going to come in. What's in lenticular? Lenticular nucleus. Putamen, it's the ice cream in the ice cream cone. Putamen, pallidus externa, pallidus interna. Okay? So lenticulostriate should be those plus some caudate. Okay? But there's one more, which is this, which is the recurrent artery of Hubner, which comes off the anterior cerebral. And why is it called recurrent? Because it turns around. So it comes out, but its target is way back here. Okay? And its target is going to be the anteriormost portion of the head of the caudate. So that its vasculature is displaced, probably because what grows disproportionately in humans as opposed to other animals? Prefrontal cortex. So that it basically pulls the anterior cerebral and the branch origin point of the recurrent artery of Hubner way anterior. In most other animals, it's not anywhere near as far anterior, so it doesn't have to change direction. So this is known as the recurrent artery of Hubner, or the medial striate nucleus. Here is a beautiful dissection. This is the optic chiasm, right here. Okay? This is the internal carotid. This is the A1 segment on this side. This is the A1 segment on this side. Here's the anterior communicator. You can see the vessels just sort of kiss. Here's the A2. Here's the A2. Here's the recurrent artery of Hubner. And here's the recurrent artery of Hubner on this side. Now, the teaching is that it usually comes off the A2, but in fact, it comes off anywhere from the point of the ACOM backwards. So it's another one that is a subject to variance. The correct answer on exams is off the A2 segment, but it's not actually true. This is Hubner. He's actually a pediatrician. He was involved early on, and one of the diseases that basically the disease that gave rise for everything that anybody studied was syphilis. And syphilis causes an endarteritis with vascular infarcts in distinct territories. And that was one of the things that Hubner studied. And he described this and was able to recognize that when that vessel was the one that was inflamed and thrombosed, you got a separate segment of abnormal infarct in the caudate. So what do you see? What looks good and what doesn't look good? So remember, left is on the left. So left hemisphere look okay, right hemisphere look okay. Right side looks okay. Let's think about some anatomy. Where are we? This is the, right here. Well, where is it sitting? Sitting at the foramen Monroe should be the anterior nucleus of the thalamus. If that's the anterior nucleus of the thalamus, where's the caudate? Yeah, tell me where to go. Yeah, there's the caudate. What's this? There's our putamen. GP, excitatory or inhibitory projection neurons. Inhibitory. This is GPI. Projections. Where does it go? 2 fiber bundles. Yeah, it goes to the thalamus, but the 2 fiber bundles that it sends out. Ansa lenticularis and the lenticular fasciculus that form the two sides around the subthalamic. They turn and are joined by the fibers from the cerebellar dentate, okay? And together they form the thalamic fasciculus, okay? What's this bundle right here? Yeah, I heard the words. Optic tract, okay? This is corpus callosum. See it? I can see a tiny vessel right here. What would that be? Yeah, it's the anterior cerebral artery running along the medial surface. Runs in front of the corpus callosum and then up over it. If you thought about that, put your hand on the medial surface of the brain. It should be that anterior cerebral territory. Okay? And what's going on in the other hemisphere? Anything good? Yeah, I mean, you get a choice. Which hemisphere do you want? Okay? Yeah, you don't want... What's wrong here? Let's follow the cortical ribbon. Looks okay. What happens right there? What happens to the cortex? Look the right color? No. It's got some hemorrhage in it, maybe? Where does it become good again? Yeah, right about here. All right, what vascular territory is that? Middle cerebral. That's a complete middle cerebral territory infarct. Okay? What's out? The cortex. To Kike's question. The white matter. What else? Well, here's our thalamus. The thalamus is actually mostly okay. Where's thalamus mostly supplied by? Posterior communicator and posterior cerebral. So if you're perfusing it from your basilar to your P1 into your posterior cerebral, you've kept your thalamus alive. But how about your caudate and your putamen? Where do those lenticulostriates come from? Middle cerebral. Lenticulostriates are out. It's all dead. This whole thing is dead. Okay? Where's the boundary between the anterior cerebral and the middle? Well, right there, right where I drew it. Right? In that boundary in the middle frontal gyrus. Okay? Look where it is. It's on the lateral aspect of the temporal lobe. Which are the vascular territories? We've already said that this one is middle cerebral. What's this? What's this? Yeah. Okay. Now we stepped forward. What? This is about 5 days out, and that's why it's beginning to fracture and come apart and crumbly. Yeah, no, I mean, some parts of it are a little more hemorrhagic, some are not. It's just beginning to autolyze. Now where are the boundaries? Well, here on the cortex, this looks like a boundary here too, okay? And in fact, all of this is dead. You can see the fracturing and the clefts there. But look at what's happened here. Why is this part of caudate and putamen intact? And the answer is our friend the pediatrician. That is supplied by the recurrent artery of Hubner. Where does the recurrent artery of Hubner come from? The anterior cerebral. So in this person who's got a complete middle cerebral artery occlusion, that will be intact. And that's the anterior cerebral artery portion of it. And this is a good example of what its territory is. Okay? Nucleus accumbens is in that territory. And as we'll see on Friday, why that's important for keeping you motivated to remember, so that you remember about an exam week from this coming Friday. All right, so when we think about those, think about the anatomy again. Here's the Sylvian fissure as the middle cerebral comes out to run along the lateral aspects. as it runs across here, there are these lenticulostriates. They come straight in, right into caudate and putamen. They don't come as far forward as where the head is. That's captured by that branch from the anterior cerebral that has now been stretched and displaced by the huge growth we have of prefrontal cortices. Okay. The choroidals, just so you're aware of them, the anterior comes from the middle cerebral. It's that choroid plexus. It also supplies optic tract. What happens if you lose that vessel and you infarct your optic tract on the left? What do you lose? All visual information from the right side of the world. Okay? You'll probably also lose information that's going back to the colliculus. And you may well even lose much of your pupillary response. Some of that travels in the optic tract. Some of it probably travels in closer. Wraps around the peduncle. What happens if you infarct your peduncle? What are your big things you're going to lose? Corticospinal tracts. Okay? Anterior hippocampus and some thalamus that we'll talk about later. So where are those? Well, here's this choroid plexus draped through in the temporal horn, and it's going to be everything that's in that anterior portion as the vessels come through the sylvian fissure. The posterior choroidal is off the posterior cerebral. It's got some thalamic contributions, hippocampus that we'll see, and it's the counterpart of the thalamic perforators, these vessels that run straight in to give rise to deep vessels. So posterior choroidals off the posterior cerebrals back here. So when we look at these in the horizontal plane, we've got caudate, putamen, pallidum, and thalamus. Thalamus is medial to lateral. Much of it is lateral to where the caudate is. Lots of it is posterior. Okay? We will have a small component that comes from the anterior cerebral for the head of the caudate, especially the ventral head of the caudate. Most of the rest of caudate, putamen, and pallidum is going to be middle cerebral through those lenticulostriates, along with much of the internal capsule. Thalamus is mostly from posterior cerebral, the thalamic perforators, and the posterior choroidals, and the thalamogeniculate, all of which come from posterior circulation. So our thalamus is much more dependent on the posterior. Our caudate, putamen, pallidum are much more dependent on middle, with a little bit on anterior circulation. And then here, these are in the slide deck. This is now everything that we've talked about in terms of which vascular beds they come from. And you should be able to say what are middle cerebral, posterior cerebral, anterior cerebral, superior cerebellar, inferior cerebellar, ICA or PICA, vertebral, and basilar. All right. And you should now be really familiar with this and be able to sort of do the version that doesn't have all the names as well as the cranial nerves on it. All right. On Wednesday, we will be back in sync and we will be back to hippocampus, so the alignments for assignments and all should be all set. And I will see you then.